Good morning, every viewer and listening to me. I am Dr. Nwako, CNN, a clinical pharmacist, assistant director in FMC Owerri, Imo State. I have been a preceptor for many world rounds, and I want to use my experience during the when I acted as preceptor or preceptorship. I want to express my experience so that this thing will help in changing the image of pharmacy practice in Nigeria. You know, in Nigeria, the pharmacy schools are yet to take full control of the clinical practice. We are not fully into the clinical practice, but the essence of this presentation is to assist some schools and some hospitals in doing their presentation, clinical presentation, world round. Now, I want to use this opportunity to dedicate this presentation to CPAN, Clinical Pharmacists Association of Nigeria, and the Association of Hospital Pharmacists of Nigeria. I want to commend them on what they are doing to clinicalize pharmacy practice. Now, I tagged this presentation a suggested model for pharmaceutical transition from classroom practice to bedside clerkship. We are talking about the bedside clerkship. Now, this presentation is for both the hospital pharmacy and universities, schools, pharmacy schools. So the first point I'm going to talk about that there is need. Yes, we appreciate that many schools are now turning into PharmD, from PharmD to PharmD. There is need to rush to urgently turn to PharmD, because PharmD is more of bedside or frontline pharmacy care, where you interface with the patient. Another important point I want to talk on is the need to consider award of PharmD by pharmacy school, and probably consider diploma in pharmacy in public health, especially pharmacy public health. It's very, very important. They are doing it some schools abroad. We can do it, we can innovate it. We don't need any other profession to start it before we rush. Pharmacy is all about public health and clinical. So we can begin to award PharmD and diploma in public health, in pharmacy public health. Another important thing I want to talk about is we need a clinically competent and skillful tutors for hands-on and experiential pharmaceutical care provision. Yes, we need people that are grounded in pharmaceutical care, and then they are clinically sound. Otherwise, if we have some people that are not too competent clinically, it will affect our product, because the product of what you have is based on the input you have. Now, first of all, there are categories of lecturers or tutors I want to involve in training of clinical pharmacy students in Nigeria. Now we have the university lecturers. Now, university lecturers that are supposed to be involved, supposed to have the basic PharmD and fellow of postgraduate, they are supposed to be fellow of postgraduate college of pharmacists in that state relevant area. Another one is that we need to have hospital-based clinical pharmacists as preceptors, and they are supposed to be the actual pharmacy round team members. Another important one is we have to talk about community pharmacy-based clinical pharmacists, because we are talking about community pharmacists. If you watch what is happening, some people are saying they can't distinguish between pharmacy and pattern medicine. So we need to make it so that we can edge them out. Then another issue is issue of industry and production. Pharmacy-based clinical pharmacists, we need them to come in, because when we are talking about pharmacy production, pharmaceutics, it has to be clinically organized. Another one is we need the research, those that are around the research and development based clinical pharmacists. Example, those that are working in clinical trials and something like Nigerian pharmaceutical, they call it NIPRID, research and development. Those people, we need them. Then we need another set of people, public health-based pharmacy. Pharmacists, clinical pharmacists that are working in public health, we need them. Like those that are working in TB or HIV centers, we need them. Infectious disease. Currently, we are talking about COVID-19 and the NCDC, Nigerian Center for Disease Control. You see, the impact of pharmacists are now being called upon. So we need people in that area so that they will equally be training us So with all these things, with all this type of and others, we are sure of having a kind of clinical pharmacists that are competent. It's not only classroom lecturers that will teach our clinical pharmacy students, especially those in Fambi and Co. But when we have all this team, we have a very wonderful, formidable team. Now, another area I want to talk about is the need, as I said, there is need for us to review the curriculum, pharmacy curriculum. The pharmacy curriculum needs to be reviewed, because if you watch, I thank PCN for what they are doing and what they've started doing, because our curriculum has to fall in line with what is obtainable in the country. You understand? So another one, the issue, that's why we talk about the urgent need to tailor our courses. There are many courses we are offering that is more of cramming structures. Your cram structures, at the end of the day, you come to hospital environment, the patient is not all that linked. We need to tailor all our courses so that it will be clinically relevant. All the courses from cognitive, PharmChem, all those courses, we need to make it so that it has clinical relevance. It's not the issue of cramming structure. In abroad, nobody's cram structure. Then another important area in that aspect in curriculum is the need to incorporate relevant clinical courses. This is it is high time we started considering courses like oncology, veterinary pharmacy, pathology, pathophysiology, geriatrics, human relationship. We need to study courses on human relationship, conflict resolution and conflict prevention, because sometimes when you enter the world, there may be professional conflict. So we need to talk about conflict prevention and resolution so that our students will know how to behave. Now we talk about laboratory investigation and interpretation. We need to know all this. Then we need to talk about the interprofessional collaboration. Pharmacy or anything on health is all about teamwork, professional collaboration. Another important aspect in that curriculum is that they need to introduce and integrate complementary and alternative medicine practice into pharmacy practice. It's as if we are, leaving those in alternative. Herbal, yes, they are herbal. We may say that what they are producing is not standardized, but pharmacognosy is there, the pharmacists are there. It's high time we incorporated them. Watch Madagascar and their COVID product. We can bring in what the nutraceuticals, food supplement and co. So we have to integrate that. Another important point I want to discuss on is the division of pharmacy academic program. I want to make a kind of suggestion that we have an academic program which I divided into preclinical and clinical stage. Now the preclinical stage is from year 1 to year 3 for PharmD. I'm talking about PharmD. Those that will reach 6 years. Year 1 to year 3 is supposed to be preclinical. This could run under semester program. Yes, we can run it under semester program. We have problem of ASU strike and co. Then another important thing is that we should have most basic pharmacy courses being taught here. So that's preclinical. Then the other one is the clinical stage, which I group as program. I don't agree with the idea of running a semester program. Watch the medical student, watch the nursing student. These are our professional sisters or colleagues. They are running a full-time program. Why should we be rushing and rushing? Clinical, you need enough time to train your student. If ASU is on strike today, it may be tomorrow. So let's have what I may call a full year program for our clinical students from 4th year to 6th year. Then we have to talk about 2 clinical and patient-related courses here, like the courses I asked. I said we're supposed to introduce like oncology and others. This is where we're supposed to teach them. Now, I want to talk about clerkship, types of clerkship in undergraduate. Now, based on the kind of training we are experiencing and the kind of pharmacists, clinically competent pharmacists we are envisaging, I want to suggest that we have 3 or 4 types of clerkship. First of all, we have the first one in our year 2 or year 3. This one will be industrial IT, industrial-based, industrial training, industrial-based clerks or training that will be for maybe minimum of 8 weeks. That will help our students to be grounded in terms of production. So that's first. Another one is the one I talk about, the one we will shift to our fourth year, and that is community pharmacy clerkship. We need to go to community pharmacy and do clerkship, yes, so that we improve our image. We are talking about community service, and I am suggesting that we do it in our year 4, 8 weeks minimum. 8 weeks minimum, so that we'll be sound in community. The other one is the hospital-based clerkship, which I suggest that we do it in year 5 and year 6. Most times you discover that our clerkship, the one we are doing currently, is 8 weeks. 8 weeks is not enough. Anything we are doing 8 weeks. Watch our work. When you are doing something, you compare something. When you are doing clinical trial, you compare to either another drug or whatever. So if we are comparing ourselves with other sister professionals, I don't know why we should do 8 weeks program, especially for those that are in B Farm now. For those that are running B Farm that may not turn to Farm G, maybe later they will come in. We need to change their clerkship. I don't understand how we can use 8 weeks to, you see, most times students, pharmacy students, undergraduate students are sent on clerkship. 1 week for pediatrics, 1 week for that. What will the student learn? The student does not even understand what is going. Before you know, it's over. So I suggest that for our B Farm, current B Farm now, we introduce this clerkship for at least 4th year and 5th year. So that at the end of the day, those with B Farm can at least be clinically competent. If they now come tomorrow, they can now do their Farm G and convert. So that's for clerkship. Now let me talk about what I may call preclinical skill and training before undergoing through clinical rotation. We need some skills and understand them before we enter into the world, or we go into clerkship. Now, the issue there is that the first point I want to talk about under that preclinical skill and training is training. We have to organize training and lecture that are targeted to improve the courage, the esteem, self-esteem, and psychological competence of pharmacy students. Most times you see that pharmacy students, when they go into the world, they are kind of psychologically timid. It affects them. They feel as if they are visitors in the hospital. No, that's not supposed to be. So we need to prompt them by giving them lectures that will boost their morale and competence. And then another important point is students should be tutored on the existence of team spirit. That this thing we're talking about team spirit, interprofessional collaboration. We talk about interprofessional collaboration. Now, another important point there is varying patient behavior. We need to teach patients on varying patient behavior and factors affecting that. Sometimes you go and see some patients who may have some psychiatric problem, or who may not even want you as a pharmacist to come close to them. So we need to teach the students how the behavior, how they can pamper such people and get what they want. Then we have to talk about conflict resolution and prevention. Sometimes we are talking about access to patient, entrance to the ward, access to folder. Sometimes you drag with other students or colleagues. So we need to equip them and tell them how to do it. We need to tell them. Another important thing, the need for adherence to pharmacy or hospital ethics and code of conduct. Yes, we need to. We don't need to go into the world and abuse people or abuse patients or whatever. No, we need to keep to the ethics, to the conduct, professional dress code. You need to be on your white coat, overall coat. You dress white with your name tag. Now, another important point in that is the need for good communication skill. These are preclinical trainings. The need for good communication skill, interview skill, and counseling skill. You don't just rush to any patient and begin to interview. Some patients, you rush to them, they tell you that the physicians have interviewed them, this one has interviewed them. So you need to still know the skills. Even if the patient is not willing, how do you pamper this patient and understand that you are there to help him in the area of his drug and others? Now, another thing is that we need, under state preclinical, we need to equip and acquaint pharmacy students with specific specialties. What are they're supposed to know before they go into the clerkship or ward round or clinical rotation. They're supposed to know what is pediatric pharmacy. What are those things that you call pediatric pharmacy? Like in children pediatrics, they are made up of there are more of water. So water soluble drug, effect of water soluble. If you are giving fast soluble, they need to know everything about their kidney, their liver, geriatrics, the drugs that are used in children and not children. We need to bring them, call it pediatric under clinical pharmacy, call it pediatric pharmacy, geriatric pharmacy, and others. And we need to again inform our students about the specific terminology and abbreviation and medical terms specific to each specialty. You don't rush into the folder. Sometimes you carry the folder, you read it, you don't understand it. Like you may see where they wrote S superscript 0, L superscript 0, K2 superscript 0, SLK superscript everywhere, then 2 in K. That means spleen, liver, both kidneys are normal. So our pharmacists are not supposed to understand what this thing means. Now, another thing is that sometimes you may come to the folder and see what they call PPH. You are wondering what is PPH. You're supposed to know what is postpartum hemorrhage, and you know that you are in ONG. You may see something in another area, another specialty, it may mean another thing. So we need to know it based on each specialty. Then we may see CVS, cardiovascular system. So we know, so we're supposed to know this terminology and application. Another important point is the need for our students to refer cases of any ambiguity or confusion. When you are going through your word round, you discover any problem or challenge, any ambiguity, or you identify any drug therapy or drug-related problem, you need to refer it to your senior pharmacist and your receptor. In other words, we should have what we call intra-professional referral. We're supposed to be referring to our senior colleague. Don't rush to the physician and tell him that you are wrong or you are right. No, you refer to your senior colleague so that you'll be sure, doubly sure. Avoid direct confrontation. Students, we should avoid direct confrontation with physicians and nurses. That's important. Then, another important thing I want to talk is the need to remind students to follow in providing pharmaceutical care process. Whereas this what we call for this pharmaceutical care process, we know it. I'm only emphasizing it for our students. All pharmacists to know it, but we're supposed to know that there are steps we should follow in establishing pharmaceutical care process when we are doing our ward round of providing pharmaceutical care. The first one is, as usual, we establish professional and therapeutic relationship with the healthcare providers and with the patient and patient relative. You introduce yourself as a pharmacy student by name, put a smile. You know, patient is under stress. You put a smile, try to win him, try to engage him, then inform him why you are there. Another point is you gather objective and subjective data. Yes, we know how to gather this, folder, interview and co. Then we evaluate, validate prescription to identify, prevent or resolve any drug therapy problem. These are very, very important things we're supposed to do. Now, again, another step is pharmacist intervention. After you've discovered any drug therapy problem, whether drug therapy problem or no drug problem, your intervention, pharmacist intervention, and then outcome. You now do it by having a good care plan. Another point is that we talk about monitoring of therapy and patient, your assessment, and then the outcome. You monitor the patient. That involves monitoring. And then lastly, we do documentation. Different books have their own. At least I know Professor Asoko Para of University of Benin. I think he has something like this or something related to that, because that Professor Asoko Para is a very wonderful clinical pharmacist. Now, another important thing is the need to respect the patient, other care providers, and maintain secrecy and privacy of patient. We must be taught how to, because I'm still talking about preclinical requirement. We must try to keep patient secrecy or privacy. We don't expose it. The nurses, we should look at the nurses as custodian of patients, because sometimes you don't expect a nurse or a physician to walk into your pharmacy and do one thing. You expect the physician or the nurse to greet you, at least accord you respect. So also we need to know that the custodian of patients in the world is the nurse. We need to make them friends so that they will help us. Now, the need to ensure that pharmacy, another point is the need to ensure that pharmacy or drug round is not a fault-finding activity, but a collaborative one aimed at improving patient care. Sometimes you see some students or some overzealous colleagues trying to enter the ward and trying to find fault. No, it's not fault finding. If you make the physicians or the nurses see you as a fault finder, they will frown you, they will frustrate you. But when you make them, even if they are making mistakes, you make it professionally. After all, you are an expert. Even if they make mistakes, no problem. You try to collaborate with them. Don't make it a fault-finding venture. Otherwise, they're frustrated. Now, another important point I want to talk about under preclinical requirement is there should be need to use a public hospital with specialties, all these basic specialties, pediatrics, oncology, ONG, drug information. But if we don't have such, we can use a private hospital, a big private hospital that have all this. It can serve. Now let me go to clinical bedside, the actual clinical bedside frontline activity. Under the bedside of clinical frontline activity, this is the actual clerkship. Now the need to have clinically competent and adherent preceptors. We need to have preceptors that are clinically competent and they are adherent to real clinical practice. And then a pharmacy round squad. We need to have a formidable squad. You see, there is a point I'm trying to make. The idea of one pharmacist as a preceptor or clinical pharmacist going into the ward is not the best. Watch the physician, they go as a team. Watch the lion. The lion attack as a group, the den of lion. And that's why much glory is always given to the lion. No? We should learn from the lion. We don't need to have one pharmacist going. You need to have several pharmacists so that if you don't remember, your colleague can remind you. So we need to have at least more than 2 pharmacists clinically competent in every team. The preceptor should be actively and directly involved. It's not the issue. I have been into preceptorship. Sometimes you see preceptor showing the student the word and say, go do this, do that. No, it's not do this, do that. You come and do it. You be the driver while the student watch you. Come and do it. You don't point at the patient and say, go, come and bite you, come. No, come and show example. So that when they see you, that confidence is there. That's why that calls again for the need for preceptors and pharmacists that have 8 qualities of a star pharmacist. You need to be a leader and others. Now, another important point under clinical activities, the need for pharmacists to have 2 types of pharmacy, 2 types of ward round. The first one I call is pharmacist owned or pharmacy owned ward round or pharmacy round. This one is aimed at taking pharmacy students alone in the ward and having enough time to treat cases in the form as pharmacist. So that one is pharmacy owned round. Then the second one is the one we call combined or ground round. The one we go along with the other health professionals. We call it ground round or interprofessional ward round. So we need to have pharmacist own round. And then we have pharmacy combined round. And another important thing I want to talk about this round is that when you are going for pharmacy own round, there is need for us to go at the time when we are not conflicting with other professionals. Sometimes you go, the physicians are there, the nurses are there. We need to choose a time. Sometimes I suggest in the afternoon when it's less busy so that we don't have this confrontation. But when we are now having the joint ward round, we can join everybody in the morning. And then there is need for preclinical round so that the students will go early in the morning, check 1 or 2 things for the actual round. So we need 2 types of round, pharmacist own round and then joint round with physicians and nurses. Another important thing is that the bedside pharmaceutical care provision. I want to talk about the bedside pharmaceutical care provision. You will see it in many books, but I want to just highlight it for just emphasis. Now, first point is that the way you are doing your pharmaceutical care provision bedside, so the first important, you evaluate and validate patient prescription to prevent identify and resolve any actual or potential drug-related problem or drug therapy problem. The second point is provide cost-effective drugs or alternatives on timely basis to facilitate and assist in provision of any non-available drugs. Please, pharmacists, apart from providing cost-effective drugs that are available in the hospital, we need to assist in making sure that all those non-available drugs that patients are getting from outside, that will equally help. Some of them will go and buy some brands that are funny. So there is need for us to equally help them in identifying and ensuring that these drugs they bought are equally in line so that we don't spoil the treatment. Otherwise, some of them will go and buy cheap ones that are fake. Now, another important thing is improve and sustain patient medication adherence and compliance. We have to be involved in improving and sustaining patient medication adherence and compliance. Some patients don't even know why they are taking drugs. They are seeing it as punishment, so we're supposed to provide some pharmaceutical services. Another important aspect in the bedside provision of pharmaceutical care is counseling patients on drug use and provide other drug information. And when I mean other drug information, I mean we have to educate the patient on the indication of the drug, the doses, issue of missed dose. Sometimes patients miss dose. What do they do? Some of them will go, we swallow 2 or 3 times to cover up. So we're supposed to give them information. If you miss this dose, what you are supposed to do. Side effect, adverse drug reaction. If there is toxicity, you can tell them home or first aid measures. What you may do before coming to hospital. Poisoning, in case of toxicity and poisoning. Drug interaction, things they will take. Will they take their food, drug with food or without food? Some of them are not aware. You're supposed to bring it. Some are even using hot water. Contraindication. We're supposed to talk about timing. When are you supposed to take? You don't just take drug twice a day, maybe for antibiotics. It's based on what time, the effect of time. Then route, field, as I've said it, are you using coke? Are you using water? Are you using hot water? Storage of drug. We don't hammer on storage of drug. That's why some people will use a good drug and put it in hot place and spoil it. Then issue of refill. If this drug is finished, what do you do? Do you go to market or go to pharmacy? How do you refill it? You need to come back. And then discard of expired drugs. Do you know that drugs, when you dispose them ordinarily, they can add to the soil and cause toxicity, and they will be damaging the soil. Issue of environmental safety in environment. So we're supposed to, how do you discard it? We're supposed to teach them. And another thing is that we're not supposed to tell them about provide disease education. Disease education, the pharmacy is supposed to do signs and symptoms of the disease, risk factors, preventive measures, including dietary and lifestyle modification. Do we tell them? Somebody that has ulcer, do you tell him that fried food, peppery food, high calcium-based products, unripe fruit? We have to tell them could worsen their disease or ailment. Then we're supposed to tell them about prognosis of this disease, so that they will adhere and comply. Then complication to improve patient quality of life. We're supposed to talk about complication. Another important aspect is therapeutic drug monitoring. We're supposed to talk about therapeutic drug monitoring. Most times when you're talking about rare therapeutic drug monitoring, you use high technology, instrumentation, high power liquid chromatography. All those things can help us. Now, but when we don't have it, we can talk about indirect assessment through surrogate markers. Maybe we check the BP. You check other things. If it is sugar, you check the sugar level to know whether drugs are working. Then we should talk about interpretation of lab. Not when we interpret the lab value, we note patient fresh complaint. These are the things we're supposed to do. Check the lab value and interpret. Now, another thing is to provide post-discharge pharmaceutical care. We need to be providing post-discharge pharmaceutical care. When you are going to ward, this patient, when they discharge the patient, you leave the patient to do. Some will go and abandon their drugs. So we're supposed to provide post-discharge pharmaceutical care. That makes you a professional. That makes the patient to value you. Now, the last one is documentation. We're supposed to document. Now, another point I want to talk about is, I want to say something. Clerkship is a bedside activity, not a classroom activity. It's sometimes not proper for some students to be taken for clerkship, and you see students being clerked in the classroom. No, you don't clerk students in the classroom. It's not a classroom issue. It's a bedside issue. When you are clerking the patient, the student can look at the history, check the folder, look at the physical examination. If you are talking about pedal edema, they will see it. If you talk about yellowing of the skin, they will see it. Other things, they will see it. Edema and co, they will see it. Ascites, anasaka, they will see it. So it's a bedside something. And then all clerkship must use live cases. The idea of using discharge note folder or using hypothetical cases doesn't do us well. We're supposed to talk about live cases, patients that are still on admission, except where there is no case. That one is a different thing. Or we're not supposed to use live cases. We need to compare the history, lab investigation, and physical examination. That makes it a real clerkship, not just classroom discussion. Another important thing is the need for, as I said it before, I've already said it, we do pre-round 4 and then full round. Now, clerkship should have the highest credit load. Pharmacy is talking about clinical pharmacy. This is the era of clinical pharmacy. We're supposed to give clerkship the highest credit load. Just like in pharmaceutics, they give dispensary. Pharmaceutics, they give you 60 marks. We're supposed to make clerkship 60 marks as pass mark, because without it, what are you? You're supposed to have the highest mark. That's the most important thing. That's my view. Now, I want to talk about on something I may call assessment of student and preceptor, academic and clinical performance. How do we assess student and preceptors on academic and clinical performance? Very, very important. Now, I want to talk about preceptors assessment, where the student assess the preceptors. Preceptors' performance is supposed to be assessed by students. Students are supposed to provide a feedback on preceptors' performance. That's why you fill in what I may call a form. It's not for punitive measure, but for improvement. Because if we don't do this, how do we measure what we are doing and making sure that the preceptors are in line with what is needed? The second one is student real assessment. Student real assessment, I want our pharmacy schools to at least look at this area I'm talking of. Student assessment, this is how can we assess our students clinically in the world. Now, I have to suggest which most schools are doing that, but I want to just add one or two things. Continuous case presentation on each specialty post. When you are posted to something like pediatrics, you're supposed to have individual case presentation on short cases. And then we have group presentation on long comorbid cases. Individual can do on short cases. Group can do on long and comorbid cases. We're supposed to do it on every specialty. It will help us. Now we talk about bedside vival. How do we vival our students clinically? Yes. First of all, I'm suggesting something. We can start it. I know some have started it. We can go ahead with it. First of all, we look for a hospital, either private or a public hospital. The pharmacy student will have the ward. The student will be coming one by one. You time the student to assess them on individual basis. When you time the student, allow the student to go through the folder, examine the patient, and if possible, take history within a timed period. Now, you assess the ability of the student to identify, prevent, and resolve a drug therapy problem. As an examiner, you don't look in whether the student can identify, prevent, and resolve a drug therapy problem. That gives him a score. Another one is you can assess the patient on his ability to counsel patient on drug. How you can ask the student to counsel this patient on drug. and then you watch, you assess the student. Another one is you can assess the student ability to counsel patient, that's educate patient on disease. How the student how knowledgeable the student is on that disease. Another important thing is ability to evaluate and justify prescription. Let the student evaluate and justify the prescription, whether that prescription is correct. We can look at it. That's a way of measuring student clinically. Another one, you can look at the ability of the student to explain the pathophysiology. You can look at a disease, let me say diabetes mellitus or diabetic foot ulcer, and tell the student, explain the pathophysiology of this disease. It's not the classroom or internet cramming. This one is what he's seeing. You can ask him, this thing you are seeing, this edema, can you tell me the pathophysiology? How did it come about? That will give you, it will help us as a profession. Another thing is the ability to interpret lab results. You can ask the student to interpret the lab result. Maybe you look at the issue of potassium, so that when the patient look at the lab result, I'm saying something like potassium, hyperkalemia or hypokalemia, you now weigh his ability to know that a drug like digoxin should be used with caution. So these are the things. We can look at the lab result. And then another important thing is the issue of comparing. You can ask the student to look at the treatment the hospital is using or the physician is using and say, compare this treatment guideline with WHO guideline or with Nigerian guideline or with American Heart Foundation guideline or with American Cardiothoracic Association, and let the student criticize it and compare. That will be a very important thing. And another important thing is, another area is that we can ask the student to design a post-discharge pharmaceutical care procedure for the patient. Let the student assume that this patient is being discharged. You now ask the student, provide a post-discharge pharmaceutical care intervention and see what the student can do. So, based on all this information I've given, I am giving it not because I know it all, but because I've been involved in several world round preceptorship and clerkship, and I saw a lot of things that are happening, and I decided to bring this thing so that it will help us in amending or guiding those that are yet to start. And then, as I said before, I want to use this opportunity again to call on all pharmacists, to please join the association of this Clinical Pharmacy Association of Nigeria, SEPAN. It's a very wonderful association that will change the image of pharmacy in this nation. Even the Pharmacists Council of Nigeria is doing its best. The Association of Hospital Pharmacists, they are doing their best. Pharmaceutical Society, they are doing their best. So this is a short recommendation I have given. My name is, again, Dr. Nwako, CNN. I'm a clinical pharmacist, a member of SEPAN, Clinical Pharmacy Association of Nigeria. This is just my presentation.
My very senior colleague, Dr. Ibrahim Bello, a deputy director, is in charge of drug information in the University of Ilorin, Kwara State. Most came with my sources and other things we are doing. We've been doing it together. I must thank you and pray that we continue to roll out more things that will help pharmacy practice in Nigeria. Dr. Bello is a very wonderful, erudite scholar, clinically sound pharmacist. I use this opportunity to thank you, my Oga. Thank you for the presentation. Thanks.